I would say that all the three speakers have really stuck to the theme of the conference, old questions and new answers. Dr. Anuja has told us to counsel beyond fertility, beyond infertility, thinking about the pregnancy aspect. When we are counseling our patients, generally we tell them you have to lose weight because you want a good pregnancy outcome, saying that we need a positive pregnancy test, but we don't go beyond that and we don't consider what is going to happen to her during pregnancy. So that is a learning point from her lecture, telling that we need to tell the patient that weight loss is not just important to get a positive pregnancy rate after ovulation induction, it's beyond that. And then Dr. Amit has told us again, he has emphasized upon this importance of losing weight and having a good ovulation induction outcome, and of course he has stressed on the point that letrozole seems to be now the first line drug for ovulation induction. Dr. Kedar, in his talk about ovulation, about adjuvants, has very nicely described all the ones that we are using, and I'm very happy that he has not touched upon DHEAS, which every third person is using for every patient. So even in hyperandrogenemia, we find prescriptions of that all around. So with that, the house is now open for questions, and I'm sure you will all ask questions from our three speakers. Let me begin then, Anuja. In my part of the country, it is very common to do a fasting and PP sugar, not just the fasting and HbA1c. Most of the prescriptions are with fasting and PP, and we do find that the postprandial is less and the fasting is higher than the postprandial. So should that be considered as insulin resistance? Do we need to think about a deranged glucose metabolism if we have that kind of a test? And then what is the treatment? How do you look at it?
So you're getting a high fasting but a normal postprandial.
Yes.
And so that's a normal impaired fasting impaired glucose.
Yes.
And the prediction of an impaired predicting diabetes is higher than a fasting predicting diabetes. So actually the patient is a little better off, I think, if you're only getting fasting high, because the body can compensate after a meal or will compensate during pregnancy, and they may be a slightly lower risk. You could get away with just doing fasting levels, then why even put them through 2-hour, right? Most of our patients don't like to do the long 2-hour GTTs,
That has been
and if
the
you're
kind
picking
of trend in North India, I suppose, we've been doing it. That's why I asked.
Yeah. But in general, I think if they have a family history and a fasting is high, I would do the same kind of counseling. If the weight is high, I would counsel about weight management. And they are higher risk than somebody whose fasting is normal. Mm-hmm. So they're already in a slightly higher category. But what's reassuring is that
they still are compensated.
They can compensate right now when you're checking it. Yeah.
Thank you.
That itself tells us that they are having hyperinsulinemia, and these could be patients who will then go on to have diabetes later on, because ultimately it's the pancreas overload.
That's true. Doctor, please.
My take on this is that in Indian women, at least, I think, because we are very strongly pre-diabetic or insulin resistant, I like to do a fasting and post glucose for all my patients and don't depend only on HbA1c. The reason is that very often we find that the fasting is normal but the post glucose is shooting up. Similarly with insulin, when we are trying to look for insulin resistance, we do the fasting insulin and the fasting sugar may come normal, but you do a post glucose insulin, it's skyrocketing to 300. I know it's not a standardized assay, but when you see patients with, and you don't do anything about this, they go through the pregnancy, you repeat the test at 24 weeks, you repeat the test at 28, 29, 30 weeks, you'll invariably find the sugars going up. And then you have large babies, you have hydramnios, and you're exposing that baby to intrauterine hypoglycemia, the whatever metabolic disorders are there, and those are the babies who get affected in later life. So I think when we were preparing the guidelines, international, they were talking about doing only post I think only HbA1c earlier. But when we discussed it, and I said in India, we need to have this post-glucose. And yes, they did add a line that in certain ethnicity, you need to definitely do a post-glucose sugar. So I mean, this is my personal opinion, and I find it very often that as the pregnancy advances, the post-glucose starts shooting up. So I do it quite often.
You do recommend
Yes.
doing a PP as well as
Not only
fasting?
PP, post-glucose.
Post-glucose.
Yes.
Post-glucose, yeah.
And then you find that, okay, post-glucose is high, you put her on a sugar-free diet, and they may remain normal after that. Or you may add metformin.
So how
and
much
then they
glucose
remain.
do you give? Is it
75.
75?
75. 75.
And you just cut out the 1 hour one. In the
Yeah,
GCT,
yeah.
you are
We don't do
doing
a
1
full
hour and
GTT.
So you don't do that.
Just the fasting
Just
and the
then
post-glucose. I mean, it's a very strong observation, but I feel that it helps me a lot to prevent overweight babies, to prevent hydramnios, to prevent gestational diabetes, etc. It's important.
So thank you so much.
Yeah, good morning to all. In fact, now the discussion is going on regarding doing the postprandial in the first trimester. And Dr. Sheshaya is coming up with a study now. I mean, he wants to do that 8 weeks of pregnancy, we have to do the postprandial. And if it is more than 110, then we'll have to be careful, because you know the GDM is on the rise, and as Dr. Durusha said, that we really pick it up very late, and the fetal pancreas beta cells start developing at 10th week. So the damage starts very early. So with the rising trends and our ethnicity, I think we have to start investing them still earlier and really look at that how many can develop GDM later, or whether we have to start the MNT very early. So we had one discussion regarding that, and it will be a multicentric study. So we are looking at that way now, because we have more patients who are prone to develop these problems.
So I think I agree with Dr. Durusha. See, we did some work in 2003 to show that Indians have a prandial glucose spike. And that is elucidated by the 1 hour, 2 hour. In fact, we actually, Dr. Vijay Vishwanathan from Chennai, myself from Mumbai, Dr. Tandon from Delhi, we did a study in 2003 to show that if you do every 15 minutes, say GTT, you can see that there is an early prandial glucose spike, both in normal Indian men and women, and also in first trimester, second trimester, and third trimester. We have published that data. And very clearly we see that the curves and the area under the curve of the early prandial peak is very illustrative. In the US, 99% of the A1C they have has a NGSP certification, which means that it is validated. While in India, only 3% or 8% of our labs have NGSP certified glycosylated hemoglobin. So first of all, the glycosylated hemoglobin which we get in our labs is not valid most of the times. I'm not talking of metropolis-like labs, but most of the labs which they do them. The second challenge is that the fasting and A1C sometimes misses out, particularly in the first trimester, the early likelihood of picking up a pre-GDM or a GDM. And then you get overt GDM by 24th or 28th week. And that has now been prospectively shown. And Dr. Sheshaya has a PhD student on it. We have one student who is doing fellowship with us right now at Lilavati. And we have shown that consistently, that correlate is reasonably consistent. And therefore, it's important to recognize what Madam was saying, that it's important to do a prandial glucose value, even if you can't do an insulin value. See, insulin value, if you do, it's additional. The other simple yardstick is high triglycerides. A direct manifestation of the carbohydrates we eat, if you do a fasting triglyceride after 10 to 12 hours, and if the triglyceride is elevated about 200, it indirectly tells us there is insulin resistance. So on the sonography, if you pick up fatty liver, you have acanthosis, you have high triglycerides, you have a prandial glucose which is high, even if the fasting and A1C is normal, then it is likely that this person is likely to progress into a full-blown GDM or a pre-GDM by 24th or 28th week. So those are early insights. We still need to generate level A evidence, but these are early thinking, and that's why I agree with what ma'am is saying. Sorry ma'am, go ahead.
No, I have it. Thank you. Sir, I have a question for Dr. Ganla, sir, regarding the adjuvants. Yeah, the presentation was quite nice, but I am still confused regarding the dose of the adjuvants. Like, there are no guidelines, or it's very confusing that what adjuvant should be given. As you said, there are too many drugs that are combination drugs. So, even if we do research, what minimum level of drugs should we look for, even in combinations or single drugs, to for the benefit of the patient?
See, as far as the metformin, myo-inositol, you know the dosage. N-acetylcysteine is 600 milligrams, letrozole 2.5 milligram, and other drugs like berberine hydrochloride. I think it's better to stay away from them right now. I think, I am not too convinced. Chromium picolinate. Every company comes with different packages, once a day, twice a day. So it's very difficult right now. That's what I told you. So it's very difficult to say that this would help or will not help. So you need to take the call correctly. As far as the first, Dr. Durusha, we did this study of postprandial insulin levels, and about 70 to 80 patients we have done the study, and we found that fasting insulin, fasting sugar normal, postprandial sugars normal, but postprandial insulin levels were extremely high. Even very few patients with thin PCOS also showed this. And I made it a point that only these patients I started using metformin or insulin sensitizers, because I have documented hyperinsulinemia, fasting and other tests are normal. So this is what I look at, and maybe I will continue the metformin in the pregnancy, because to prevent GDM from the beginning.
Can I just clarify one thing? I think the question, though, that Dr. Sonia was asking was fasting higher than postprandial and not pregnant. I don't want the audience to think we are recommending A1C or fasting glucose in pregnancy. That is not. The recommendation once you're pregnant is a GTT. It's not an A1C or a fasting level. I think her question was different. In a non-pregnant patient,
Yes, absolutely.
she felt like there was another group.
Yeah, there is a group.
The
yes.
most standard Indian group is you give the glucose and postprandial,
Yes.
they will be high. I think that is the standard.
Yes.
But she was talking about a different group, and hence those answers were different. But
Correct.
Yeah.
Yes.
Okay.
True. Thank you for the clarification. And I think we should thank the speakers. A wonderful session. Thank you all for being here. Thank you so much.